from the American Academy of Pediatrics.
TV shows about medicine often contain inaccuracies, and that can have a negative effect on the viewer's understanding of health.
But a new show called The Pitt is breaking the mold. It uses technical consultants to ensure every medical detail is correct.
I love what I do, and credit to all the doctors, all of us and what we do. But, at the end of our lifetime, we may change tens of hundreds, maybe even thousands of lives. But in one media clip, in one show, you can change millions of lives.
Plus, research in pediatrics shows a need to standardize the diagnosis of cerebral palsy.
It is, in many ways, a straightforward diagnosis to give, but it's also a really important diagnosis to give.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Balinki. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a discussion about medical portrayals in television and film.
Okay, Joanna, are you willing to confess that we've both been pretty excited about this next interview?
Absolutely, for so many reasons. One is we both love thinking about how people in medicine can use television and movies to educate and also advocate around healthcare issues.
And the other is that, like a lot of our peers, we were both enthralled by the TV show The Pitt, which dramatizes 15 hours in a Pittsburgh emergency department in real time. The show made extensive use of technical consultants to ensure every medical detail, from the language to the monitor tracings, was accurate. Some scenes had me reliving deeply emotional moments from my own career. I will confess I had tears streaming down my cheeks.
That has been what has made it a little difficult for me to watch because I do work in critical care, but it is so well done. And today we'll be talking with a real-life pediatric emergency medicine physician in Pittsburgh who helped the writers and actors nail so many of those details, Dr. Sylvia Owusu-Ansah. There are spoilers, so if you think you might watch the series, consider bookmarking this episode and coming back to it later.
Dr. Owusu-Ansah is Associate Vice Chair of Diversity, Equity, and Inclusion, Associate Professor of Pediatrics and Emergency Medicine, and EMS Medical Director at UPMC Children's Hospital of Pittsburgh, as well as an active advocate for the AAP Federal Affairs Office. Sylvia, welcome.
Well, thank you for having me. I'm so excited to be here.
We are so excited to have you. And Sylvia, you got such a unique opportunity with this show to educate and advocate through story. Did the creators find you or did you find them?
It was a little bit of both, probably more the former than the latter. So in March of 2024, my good friend, Dr. Beth Hoffman, who is an assistant professor at the University of Pittsburgh School of Public Health, reached out to me about an opportunity to speak with writers from The Pitt. And so she and I fantasize about a world where we can get rid of misinformation through media clips, social media, all of these things. And she's connected with a nonprofit that does such that. So the nonprofit's called Hollywood Health and Society. The purpose of Hollywood Health and Society is to bring medical expertise to all television shows. So they were created through the Lear Center at University of Southern California. And so you name it, shows like This Is Us, not just medical dramas like Grey's Anatomy, but even shows like Abbott Elementary. They work hard to bring that healthcare expertise to the platform. And they reached out to Beth and they said, we're looking for preferably an ER doctor who in Pittsburgh, who is an expert on health disparities. We want to know, what is the real deal in Pittsburgh when it comes to health disparities? And Beth said, I know just the person, reached out to me, got connected with Hollywood Health and Society, and the rest was history. They're like, we're going to put you in front of the former executive producers of ER. Now, I will admit, for those of you ER fans out there that I wasn't big into ER because I feel like I was too busy trying to do this job. Like I was too busy trying to be a medical doctor. And so like Beth knew like everything about Noah Wiley and everything about Dr. Carter and all these characters. And I was clueless. So I will say I went in kind of with naivete, like, optimistic naivete of like, oh yeah, this is really cool. I'll talk to these people. Sounds like a good thing. But circa 2025, man, I feel incredibly blessed for that opportunity.
And this sounds like such a huge undertaking. Did you have to leave your clinical practice to do this job, or how did you intentionally make time to participate in the show?
Yeah. So again, in the world post-COVID, Zoom calls. So we did a 2-hour Zoom call. And basically I was talking to the writer's room through a Zoom, predominantly led by Dr. Joe Sachs, who is an amazing human being. So he was one of the former executive producers of ER, current executive producer of the Pitt. He's a part-time ER doc. So he still works in the ER while doing the Pitt. And he's an ER doc who went to film school. Like you can't get any better than that. So pretty much he led the discussion, but got to speak to everybody in the writer's room. And they asked me questions regarding healthcare disparities, demographics in Pittsburgh. And then I threw in my secret pediatric sauce. I was like, well, I'm a pediatrician. Let me let you know some of the cases, that I think are critical in our space that we need to know. So it didn't take much out of my time or my workspace. And then I had the opportunity to go to LA for another conference related to what I do in EMS. And I wanted to thank Hollywood Health and Society for the opportunity. So when I spoke to the writer's room, they had not been approved for a pilot yet. So they were like, don't tell anybody anything. We don't even know if this is going to be a show. When I went in May, they were approved. So that was really cool. And I was like, oh, I just want to go thank Hollywood Health and Society for allowing me to do this. And they said, guess what? It's your lucky day. The writers are in the writer's room. So they took me to John Wells production studio. And I turned the corner and Noah Wiley was there. He wasn't on the Zoom call. So I literally lost my mind. And he like literally had to pick me up from the floor. He's like, Dr. Sylvia, it's okay. We're happy to meet you. They had me sit at the head of the table. And then that was another 2 hours of talking about myself and some other storylines, which I'm sure we'll talk about. But yeah, so probably a total of 4 hours, but made a whole world of difference in that 4 hours.
Well, it's still making a world of difference now. And you mentioned storylines. My first inclination was to try to list all the plot lines in the season that highlighted hot pediatric topics. But when I started, I realized we were never going to get to them in the time that we have. So instead, would you be willing to share maybe one or two real-life experiences of yours that you used to form arcs on the show?
The THC gummies.
Yes.
That was the one that I was like, people need to know that this is a problem. So that was 100% came from my storyline. And it's funny because I came back to Pittsburgh and my chief was like, that was my patient. And I was like, that is all of our patients, which is why we need to talk about it. And so, I thought it was important. We're seeing cases after cases after cases, and you both know as pediatricians, but the world doesn't know, right? And I think people take for granted, there are some positives in the use of THC in adults and things of that nature, but we still need to be careful and think about our children getting into our purses, leaving baggies on tables, and the repercussions of that, right? And so I thought it was very, very important to include that storyline. So that one, it definitely came from me. I thought it was interesting. I would give the team more of the credit. I like the arc around, in a way, looking at healthcare disparities or prejudices that we have with certain types of families. In the case of this was a white family. And, when mom, spoke up and was frustrated, those are kind of the stereotypical ways that people may view communities or families of color. And it's interesting, how they had a discussion afterwards of like, if this was a Black family, certain things would have happened. So throwing all of that into one case was just incredible. The other aspect of that was a social worker and what social workers do. So two of my closest friends, Dr. Ron Roth and Dr. Sheila Roth, also advise on the show. Dr. Sheila Roth is an extraordinary social worker here in Pittsburgh. So she advised on all the social worker aspects of all the episodes. And the one thing she said was like, the social workers don't always take your kids away. Just, she's like, please don't have the social worker be old and frumpy and don't let them take the kids away, because that's the connotation. The social worker in CYS are going to come and take the kids away. So they made a point of that as well. They just did a phenomenal job interweaving all of those aspects of what we deal with in the pediatric world when it comes to toxicology, when it comes to healthcare services and support services and social work, and how we see potentially the foster system or the idea of somebody's trying to take your child away when, we're just trying to have the best interest of our pediatric patients at heart. And so they were able to weave all of that into that storyline, which was beautiful.
I just wanted to say our social workers are the ones who get the cribs and the car seats for our families and find housing
100%.
for them. So they are critical in our NICU environment as well. But I want to get back to some of the tough things that you brought up. The show does dramatize racism and sexism in healthcare, with both healthcare workers and the patients as victims. I'm curious how your work in diversity, equity, and inclusion might have informed some of those scenes.
Yeah, so the one that I am probably proudest of, and it was direct from the headlines, it was actually a case that I dealt with this was the patient with sickle cell. In my real world case, it was a 17-year-old. So it was a pediatric patient, but it doesn't matter, right, in this case. And so that was the other thing that I said, that people really need to recognize prejudices around pain management and health disparities around pain management and sickle cell disease, and understanding how bad bone pain is. It's hard for us to comprehend. And, people like to do this, like, the texting test of like, oh, the sickle cell patient came in and they're texting on their phone, so they must not be in a lot of pain. They must be drug seeking, right? And we know that for our Black and brown communities, from the 80s and 90s, the crack and cocaine epidemic and all of that stuff, this community has been, plagued with the idea of drug seeking, gang banging, all of these, preconformed notions, whether unconscious bias or overt racism. And, this is a great opportunity to say, no, if you look at the pathophysiology of this, you would be doubled over. These folks are actually, brave, and, they have to deal with this every single day of their lives. They don't come into the ED every single time that they have a pain crisis, but when they do, it's really bad. And it's like, a clogging of the plumbing in your bones, where you have these abnormal blood cells that look like sickles, and they're sticky and they're coming together. So it's like clotting and pain and all the things combined, not to mention all the other comorbidities that they could have, like stroke, infections, things of that nature. And so that was a real life case where I had to stand up for my patient. So everything that they did, I was like, when I watched that, I was like, oh my God, they really took that. And so, the actress who plays Dr. Mohan, or Slow-Mo, I thanked her too. I had the opportunity to DM with her on Instagram, and she's like, no, this was really important. So yeah, the sickle cell case was directly from the headlines.
I really wish that case did not reflect my own experience being called down to the ED for those admissions, but sadly, I have heard exactly that sentiment more than once, and it's really distressing. I want to ask you about one character on the show who portrays a former paramedic from the Freedom House Ambulance Service, which was founded by Black residents of Pittsburgh's Hill District. Freedom House was both the first program in the U.S. to train Black paramedics and the first to provide advanced life support in ambulances. You're a board member of the National Registry of EMTs. Can you tell us a little bit of the history and what it means to you?
Yeah, thank you, David. I mean, that was the other golden nugget that I was able to lend to the story. So you're right. We owe emergency medical services and really the institution of emergency medicine to the Freedom House Ambulance Group. So this was a group that in 1967, so the Hill District was previously a predominantly Jewish neighborhood, and then secondary to what we call redlighting, which is the way that neighborhoods were divided or basically racially segregated without getting into the details of it, the way government and local ordinances made sure that Blacks were in certain neighborhoods away from whites and any other types of racial and ethnic groups. The Hill District was predominantly Jewish. And the Jewish community was the only community in actually many cities. If you look at the patterns of New York and Pittsburgh and some of these other neighborhoods were predominantly Jewish, they were some of the only communities that would allow Black folks to move into their community. So the Hill District transitioned from Jewish to Black. There was minimal resources in that community. Health care and health disparities were some of the most significant. in the city. And so it was recognized by many people on many aspects, many different lenses. There was a gentleman called Mr. James McCoy Jr., who was active in the NAACP at that time. And he put together like a program where he'd bring like fresh fruits and vegetables with a van, and his company was called Freedom House Enterprise, to the Hill District to bring nourishment, to this area. At the same time, you had Nobel Prize nominee, Dr. Peter Safar, former Austrian immigrant whose father fled the Nazis and he fled all of the chaos there to come to the United States, known as the father of CPR, and also was the first chief of anesthesiology at Presby here in Pittsburgh, who thought of the idea of having these street doctors because he noticed that people were coming to the hospital, nothing was happening in between, and by the time they arrived, they would be dead. And then along with Phil Halen, it's hard to do a program without money. He led the Falk Institute or the Falk Foundation, which did a lot of grant funding to support a lot of the community work done in the Hill District. So at one point, the three of them got together and said, wouldn't it be great if we created these street doctors? And wouldn't it be great if we used the folks from the community to be those people? So, unfortunately, they were deemed the unemployables, but it just goes to show that they took folks who did not have high school diplomas. Some were felons, some came from disadvantaged upbringing. Others were like Councilman Brown was a medic in the military, so astute and very well on top of his game. But it was a mixture of initially Black men and women of various experiences from the Hill District who were taught to be some of the most astute paramedics from the beginning of time. They were giving Narcan. We talk about the opioid epidemic now or opioid use disorder. They were drawing up Narcan before we were talking about, handing everybody Narcan. They were doing EKGs and transmitting the results of those EKGs to the hospital before we were. They were intubating in the field. And so just a phenomenal, echo chamber of healthcare to be proud of. But, new leadership came in the early 70s in Pittsburgh, and they weren't happy that the Black folks were getting the best healthcare, right? The most disadvantaged folks were getting the best healthcare. This wasn't happening in the white communities. So in essence, through racism, shut it down, started their own, Pittsburgh EMS, which I'm happy to say in 2025 is now led by the first Black and first female chief of EMS, Dr. Amira Gilchrist. So, it is to say that Pittsburgh EMS of today is not the one that took over from Freedom House initially in the 1970s. And they also have an EMT academy that follows Freedom House. And Chief Amira is actually the mentee of one of the original Freedom House members, Chief Moon. So it has been an incredible journey. And I am working right now to lead in getting them the Congressional Gold Medal, which Rep. Summerlee is sponsoring at the moment. So it is an incredible story. It's not a story, it's history that needs to be told and understood. So David, thank you for bringing that up. We stand on their shoulders still today.
And I hope you guys do get that medal because it's an incredible story. And, one of the aspects of this show that I found moving and difficult is that not all of the stories end well. And I'm thinking specifically about some pediatric deaths that occurred, as well as victims of sex trafficking and sexual abuse who, choose not to disclose. How did you and the writers decide on outcomes that are common in real work, but are so rare on television?
Yeah, I think, listening to John Wells, who's the producer who owns the production company, Noah Wiley, Dr. Joe Sachs, and R. Scott Gimmel's the showrunner. So a lot of these names you don't hear. You just hear Noah Wiley's name. But a lot of what we're talking about, these folks, thought about well ahead of time. The first thing is they wanted this to be the most realistic medical drama out there. And that is what the ED is, right? We are the gateway to healthcare. I think the beauty of what I do is we don't turn anyone away. It doesn't matter whether you're an immigrant. It doesn't matter what your race is. It doesn't matter your gender. Everybody that needs healthcare can come to the ED and be provided healthcare. And that's the hard, felt truth. And many of the people that come because of lack of access, right? And so they're coming at a time where they're most vulnerable, but their disease and illness process is extremely acute, right? And so they wanted to keep true to that reality that we're dealing with. And then, COVID crushed so many of us in so many ways as healthcare providers, especially our adult colleagues, and the death of a lot of our patients on a daily basis, and the death of some of our colleagues, in the amount of volume and the sheer stress. And we're still dealing with the repercussions of that today. First and foremost, they sought to make this realistic. Secondly, they understand the importance of the storyline in media and how you can touch people. And they sought to tell the story without having to point various things out. So they sought to talk about using the storylines to talk about abortion, using storylines to talk about mass casualty, right? John Wells had said, nobody said gun control, right? When the mass casualty incident happened, you didn't hear the word gun control or gun protection or whatever terms people want to use nowadays. But you recognized with a weapon what the repercussions could be through that mass casualty event, through telling that story. So you didn't have to say some of the obvious things. The other thing that telling the storyline this way allows people to see is that people that may not look like you, may not agree with you, may not have the same beliefs as you, are still human and still undergo human things. And what is the one human thing we all undergo is sickness and illness and death, right? And birth too, right? The beginning of life, the end of life, and, illnesses in between. And so I think they really did a good job of, focusing on those aspects of telling the story.
I was struck as well by how well the characters model medical communication, whether it's closing the loop in a code setting or providing patients clear and empathetic explanations of what's happening. Did you work with the writers on this language? And as a communications expert, what would you recommend for the rest of us?
Yes, so I did not. So the Pitt executive producers and team did their homework. At any one time, there are 3 to 4 emergency medicine physicians on set going over the moves, the methods. In addition to, they have social workers that they talk to, nurses that they talk to. They also had to do a medical boot camp where they had to learn how to do all of these procedures and not just mimic them. And then again, remember, Dr. Joe Sachs himself is an emergency medicine doctor, and he's always on set. So you definitely have that constant mentorship, education in a way that I don't think any other medical drama series has had, even ER. So yeah, they've done a phenomenal job with that. That's why it is so realistic, because it is realistic to some degree.
And as someone who's actively engaged in the AAP and especially the Federal Affairs Office, what policy changes do you hope will come from doing work like this?
Well, it's interesting that you say that. I am the EMS for Children's medical advisor for the state of Pennsylvania. And interestingly enough, back in the day, Mr. Noah Wiley was an advocate for EMSC, and he did a YouTube video. I can't remember if he did an op-ed or not. So what is EMS for Children? EMS for Children is the only federal funded mandate, so to speak, that focuses on pediatric emergency care throughout the nation, that helps to provide things like injury prevention, how to best take care of a child in the back of an ambulance. It also supports things like the Pediatric Emergency Research Network, where we were able to get millions of dollars in NIH funding to provide evidence-based medicine to how we best take care of children, not just in the ED, but throughout. We've worked with neurologists and endocrinologists on how best to take care of children in these spaces. And so, I think it can form to policy in so many ways, like that pediatric cardiac arrest case and talking about drowning prevention and, bringing awareness to a lot of the things that we deal with, the fentanyl overdoses and policies around opioid use disorder or access to opioids or prevention of overdose. There's so many aspects to what could be brought through this space. And we're already seeing the golden nuggets and the benefits of that, with people changing their minds after watching the Pitt about life-ending decisions, about organ donation. Even one of the actresses said that, Dr. Beth Hoffman, unfortunately, her sister got hit by a car a few years ago and passed away and was an organ donor. So we did this organ donation video. And once one of the actresses heard that we were involved with the Pitt, she was involved with the Pitt, they sat down with their family to talk about organ donation. So, it can go so many ways and so many positive ways in helping to change policy. This is actually one of the key policy things that has already happened. So you were talking about Freedom House, and we are lobbying for the Congressional Gold Medal. Well, one of the members of the Department of State watched the Pitt, and he said, I never heard of these people. I want to meet them. So we were able to arrange for this person in the Department of State to meet with the original Freedom House members. And he was fanboying and fangirling all day, asking, it was like an hour and a half session of like, when did you do this? And what happened here? And what happened here? And are there any documents? So this was in the Department of State in this current 2025 climate. So that says a lot right there. So we've already had a call from the Department of State, so to speak, or a member from the Department of State who's like, I watched the Pitt and I want to know more about Freedom House. So, things are happening in ways that I think the team from the Pitt imagined, and even more. Measles, right? So the beautiful thing, and Dr. Joe Sachs is really proud about this, is remember, they wrote this a year ago. So they wrote that measles storyline a year ago, before what happened in Texas, before the deaths in Texas. And I was recently in Hawaii, and every time I go to a different city, I join the EMS crew and I get a tour through the lens of EMS. And the chief of EMS wanted me to know that one of the pediatric emergency medicine doctors recently watched the Pitt and was reminded about the symptoms and the history around measles, and was able to diagnose the first measles case in the Hawaiian Islands. And she credits that to the Pitt. And so policies around that. So incredible how storylines can really, really change lives, and how media can change lives by the millions, right? I love what I do, and credit to all the doctors, all of us, and what we do. But, at the end of our lifetime, we may change tens of hundreds, maybe even thousands of lives. But in one media clip, in one show, you can change millions of lives and perspectives. So I think that's what's key and important.
Well, I imagine we're going to have some listeners who are inspired to follow in your footsteps in using story and media to raise awareness around health issues. And honestly, that includes Joanna and myself. So what advice do you have for people who want to follow in your footsteps?
Yeah, first I would say, just go out there and ask the questions and meet with the folks. What do I mean by that? I'm a big believer in cold calling. It doesn't always work out, but if film is your interest, and you're part of an institution, maybe tap into your local film school. Like we had Pitt Film School. If you're at Stanford, they have phenomenal journalism program. You can tap into there. If we're talking about a physician standpoint, see what the resources are in your area. Hollywood Health and Society, they're always looking for medical experts. They have this huge database of medical experts that they can turn to at any point in time, from neurosurgery to a podiatrist, to ask for any of these shows. So there are organizations like that focus on providing expertise healthcare to Hollywood, to television, to movies. So find those opportunities within and go for it. Beth and I, Dr. Hoffman and I, play off of each other. And at the end of the year, I was like, wouldn't it be great to do the Pitt premiere in Pittsburgh? But I didn't have a direct line connection with Noah Wiley. So I just called Warner Brothers. And I wasn't expecting them to answer. And they're like, hello, this is Warner Brothers. And I was like, oh, shoot, I have my pitch. But they're like, oh, you want to do that? That's fine. There's no problems there. Just reach out to Max. I reached out to Max, media and PR people, and now we have this longstanding relationship. Sometimes you just have to go for it and kind of see what happens. So I would say, one, look at the resources around you, right? That's the easiest thing, the low-hanging fruit. What are the resources around you when it comes to film, when it comes to communications, when it comes to media? Get to know your local media folks. Like the people at, KDKA or my local Pittsburgh media folks know me. And I help to talk about pediatric issues, healthcare issues, EMS issues. If you're at an institution, find if there's a local film school. There are organizations like Hollywood Health and Society. So kind of grab that low-hanging fruit, your local newspapers, believe it or not, to kind of begin to get engaged and become the expert in their eyes and build that relationship. It's all about relationship building, as we know. And then you just, you kind of go from there.
That's amazing. Dr. Sylvia Owusu-Ansah, thank you so much for joining us today.
It was great to be here. I hope to come back soon.
We hope to have you back. And to learn more about advocacy through story, go to aap.org/podcast.
Coming up, we'll discuss standardizing the diagnosis of cerebral palsy.
avid listeners of the podcast know that my father, who is 76 years old, has cerebral palsy, or CP. He's very affected from his speech to his gait, and I grew up with an intimate understanding of this chronic condition.
Yeah, Joanna, I remember you telling stories about your father, and he accomplished so much despite having a condition that can be stigmatizing.
I think part of that, David, lies in how we define it. It's a disorder that has so many different phenotypes, and the diagnosis and therapies are not always straightforward. I think if we had a clearer sense of what CP was and how we could identify it and access resources, it would go a long way for people like my father.
Well, I know someone who would agree with you strongly, Dr. Buma Ravamutan. She's an assistant professor in pediatric neurology who works at St. Louis Children's Hospital and is affiliated with Washington University.
She specializes in pediatric movement disorders like CP and is the first author on a paper in pediatrics, The Need to Standardize the Diagnosis of Cerebral Palsy. Dr. Ravamutan, welcome to the show.
Thanks so much for having me. And thanks for telling me about your dad. That's really great to hear.
In fact, Joanna did share a little bit about her father, and this paper starts with a quote from an anonymous pediatrician that says simply, "Cerebral palsy is a bad term." Do you believe it's a bad term, and is that why you wrote this paper?
I do not believe cerebral palsy is a bad term, but I do have a lot of, I suppose, sympathy for the practicing physician who might feel that way when trying to think about how to apply a cerebral palsy diagnosis to the child or the person that they're seeing in clinic. I think that what is out there currently for us to be able to conceptualize CP in a 30-minute clinic visit when you're seeing someone and trying to understand whether they have CP or not, I think it can be really tough. And so what we've tried to write about here is why we need to change that, ways in which we think we can change that, and some suggestions for how, even though CP is not a bad term, it is badly in need of standardization for how we apply it in clinical practice.
You know, speaking of diagnosing CP, my father was never given an explanation for why he developed it. And now, over 70 years later, we have so many more tests that we can do. Which ones are your go-to?
Yeah, great question. So, a lot of that also depends on the person that you're seeing. We know a lot more about genetic contributors to CP. We know a lot more about the different imaging patterns that we can see with someone with CP. I think the most important thing to highlight about what you just said is that he was never given an explanation. I think more than being very clear on you must do this and you must do this for the diagnostic workup, it's really important to note that people with CP deserve an explanation for why you think they have CP, and to do your best to figure out what that explanation could be, whether that means conduct genetic testing or get further imaging. To say someone has CP is not enough. But the diagnosis itself is phenotypic. So it's based on the features of the person you see in front of you, and whether based on those features you think that they will have a lifelong motor disability that began with a disturbance to the developing brain that manifested before they were 2 years old. That's what we outline in this paper. And then that phenotypic diagnosis is the first step to answering some of the questions that you just brought up. Why do you have CP? What are the next steps? What are the right treatments for you? The entry point to all of that is establishing that someone has CP definitively in the first place and not feeling uncomfortable about being able to give that diagnosis.
Buma, I wanted to challenge you a little bit there because as a child of someone with CP, I've seen many adults who carry the diagnosis. I also take care of a lot of former premature infants who get diagnosed with CP. And I can honestly say their motor capabilities all look a little bit different. How can a general pediatrician point to a motor symptom and know if it's CP or not?
Yes, that is a great question. I think cerebral palsy is similar to other neurodevelopmental conditions in the sense that it can manifest in a really broad range of ways. That's true for autism. It's true for early onset epilepsy. CP is the same. we do now have really great data that shows that you can accurately predict a CP diagnosis through a combination of a suggestive prenatal or perinatal history, suggesting that a child may have sustained a disturbance to their developing brain or a brain injury through suggestive findings on MRI, and kind of the overarching features of the exam that can be assessed on standardized exams like the Prechtel General Movements Assessment or the Hammersmith Infant Neurologic Examination or the HINE. Now, if you're a practicing pediatrician, that's a lot to integrate into a single clinic visit with a young baby when there are lots of other things that you're counseling that family on in the same visit. I think the good rule of thumb here, and what we've tried to highlight in the paper, is that if you are seeing a child that has motor symptoms that you think are due to a brain disturbance before the age of 2, so this child is displaying motor symptoms before the age of 2, and this may be a child that you're thinking about referring for therapies, but there are motor symptoms that you are seeing, think about CP. CP is on the list of things that you should be thinking about. And there are criteria for how to establish that diagnosis. If it's difficult to do that in that single visit, then referral is definitely an option to specialists like a neurologist or a developmental pediatrician that can help establish that diagnosis. But having the vigilance to know that early onset motor symptoms could be CP is really critical in that young baby. If you're seeing an older child who has motor disability or motor symptoms, then you, as a practicing pediatrician, I think do have the ability in a visit to really think, did these motor symptoms start before that child was 2? And by the time they're 5, did those motor symptoms manifest as a motor disability without any regression? Did they lose milestones or did they regress by the time they were 5? If the answer to that is no, then that child has CP. And I think that's what we're trying to establish here, that it can truly be that straightforward if we have standardized criteria for establishing what a CP diagnosis is.
And you mentioned history and physical exam, but earlier you also mentioned genetic testing and imaging studies. Are there any that you would consider standard, or is that something that first neurology gets a look at the child and then they decide from there?
Yeah, so in terms of sending genetic testing, some of it, in fact, a large part of it depends on access to genetic counseling. If there is that access, and I think that's a big sort of linchpin access to whether thinking about sending genetic testing in the first place. But there are guidelines out there from the American College of Medical Genetics. These guidelines were reaffirmed in a paper that a few of us came out with, led by Sid Srivastava at Boston Children's. There are guidelines that say that if a child has a developmental disability, that whole exome sequencing is the recommended evaluation, whole exome or whole genome sequencing, as a first line assessment. So this isn't, if we've gotten all of these other tests and then we haven't found an etiology, then maybe we should consider about whole exome sequencing. It's really think about whole exome sequencing first. Again, whether you can send whole exome sequencing depends on a series of infrastructural factors as well, but that is the test that is being recommended, at least through ACMG guidelines.
And when families get an early diagnosis of CP, knowing there is variability in what CP can look like, is it helpful for them?
I think it is. And we actually have data to show that it is. Families often suspect or want to learn about CP before it's discussed with them. There are really beautiful qualitative studies with families of children with CP, families of children who have been in the NICU that felt that a CP diagnosis should have been discussed earlier with them and that they really had to fight for it. I think it can be difficult as a physician or a clinician to feel like you could be wrong if you give a diagnosis and then to say, oh, I guess you don't have CP. I think there's also an inherent sense of stigma. I think David pointed that out earlier, that you ascribe your own sense of stigma about CP to a family and say, well, I don't want to give them, quote, bad news, whatever you may perceive that to be. I think ultimately families appreciate honesty. And I think the concept of saying someone is at high probability for CP, or you think that is the most likely diagnosis right now, but I will continue to follow you as we go through this journey together. Things may change. I will update you. I think families really appreciate that. And it's not just what I think. There are several qualitative studies to show that that's the case.
Well, this is a great paper for anyone who cares for families affected by cerebral palsy, but do you have any last takeaways for our listeners before they go read it?
I think a big takeaway for me in doing this work and caring for families and people affected by CP is to not be afraid of the diagnosis or in giving the diagnosis to families. CP is not a bad term. It is possible to diagnose CP in a clinic visit, in a pediatrician office, as a practicing pediatrician. It's all possible. And I think thinking about it in a concrete way, in an evidence-based way, and thinking about it as, did this child have motor symptoms due to a brain disturbance that started before age 2? Do they have a motor disability at age 5? And have they not regressed? That's it. It is, in many ways, a straightforward diagnosis to give, but it's also a really important diagnosis to give. And I would encourage pediatricians to not shy away from it. It is an important thing that we as pediatricians can do for our families, is to tell them the truth and be honest about the diagnosis that they have and walk with them on the journey of treatment once that diagnosis is given.
Dr. Arava Mudan, thank you so much for joining us today.
Thank you so much for having me.
To read the paper, The Need to Standardize the Diagnosis of Cerebral Palsy, visit our website at aap.org/podcast. At the end of every episode, we'd like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, now that I'm working in a hospital and not in a clinic, I don't often get second-generation patients. But it was a real joy to open a door for a newborn visit last week and have the grandparents and the mom go, "Dr. Hill, where's your bow tie?" So I was like, yeah, I used to wear those every day in clinic, and it was a joy to see yet another generation come into the world.
You are so fashionable, David. I'm not surprised that your patients remember that.
There are people who would disagree that a bow tie is fashionable.
I think it's trendy. And my Say is that I don't know.
That you're awake
Danny's
anymore.
been on vacation. There's been a sea of grandparents here. The kids are like feral with the iPads. I don't know. David, I'm really struggling. And so I think it is enlightening for our listeners to know that some weeks you just can't find the Say Ah.
When you've been up 48 hours mostly at a time, it can be difficult. But you know what? Your tears of laughter right now are my Say Ah.
If I'm going to reach here, it's that the bird that got trapped in our house this week was not a pigeon. It was a robin. It was just like a really lovely bird.
When you get a bird trapped in your house, you at least want it to be attractive. Well, that sounds like that's it for you, Joanna, and that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll discuss federal cuts to children's health care.
We'll talk to AAP President, Dr. Sue Cressley. I'm Dr. David Hill.
And I'm Dr. Joanna Pargabalinki. Thanks for listening.